And we will be recording everyone as well. So if you don't want your face on the YouTube, feel free to turn your cameras off.
Okay, can everyone see that? Okay, it's in presenter mode.
Yeah, fantastic.
Okay, cool. Thanks so much, Tina, for the introduction, and a big thank you to Jourdan for joining us today. I think your CHIPS program is really fantastic and really interesting. So I think we're going to have a really nice discussion at the end. I'll be presenting a little bit of work around teenagers and young people living with chronic conditions, and you'll see that mainly I'll be talking about type 1 diabetes, mainly because we've been doing quite a bit of work around that chronic condition over the last few years under a Juvenile Diabetes Research Foundation grant that's actually led from the Centre of Excellence in Children's Diabetes at the Kids Research Institute in Perth, and I have the great pleasure of leading the Models of Care stream under that quite large $8 million grant, which is coming to the end. It's been an amazing initiative and spanned 5 states of Australia and several universities looking at different aspects of type 1 diabetes. All right, so let's see if we can advance this. I'm from the Australian Institute of Health Innovation. We conduct research on health services and health systems. We're a fairly large enterprise of this type. We've got about $58 million of projects under us at the moment, and that's continually growing. There's been some successes announced recently, so that's going to be even more. We also collaborate a lot, so over $108 million in funding is shared with other organisations, and so the project I was mentioning earlier, that is a shared project across a number of different organisations. There are about 300 of us, a bit more than 300. We run about 160 projects at any one time, and we publish a lot. And here are some of us saying hello to you. We're very collaborative, and we collaborate not only across the country, but internationally, including with people like the World Health Organization, the OECD, Fujitsu, Harvard University, that was involved in our project that I'm going to be talking about as well, Imperial College London and others. And over a third of our publications include international collaborations. So just to orientate you of what we're going to do today very quickly, I'll introduce the idea of chronic disease in young people and the need for transition. Then I'll move on to transition from paediatric to adult care for young people living with type 1 diabetes. And then we'll talk about a case study of a model of care, a transitional model of care for type 1 diabetes, which has been sustained for more than 21 years at Westmead. That's unusual. Often models of care are implemented under research funding, and often they don't continue. This one has continued, and we were really, really interested in the factors that enabled it to continue and to continue growing, and also to be spread to other contexts. And then I'll hand over to Jourdan to talk about the Chronic Illness Peer Support Program, CHIPS, which is a fantastic program, again, running out of Westmead, but I believe it has been taken up in Melbourne as well, and I'm sure Jourdan will talk about that. And we hope to leave some, at least 15 minutes for discussion at the end. Please keep your questions to the end, or put them into the chat to make sure we don't forget about them. But yeah, we're going to open up for discussion at the end. Thank you. Okay, so About 20% of young people in Australia live with some kind of long-term chronic health condition, which is quite a lot. If you take the population as a whole, about 50% of us have some kind of long-term condition, me included. In fact, I have several of them, and probably will acquire additional ones as I get older. Often children are diagnosed while they're children, and so they access paediatric care, but as they grow and the condition isn't dealt with, or if there is no cure, they must transition to adult care by the time that they are 18. As you can imagine, around that time, there's lots of transitions happening for young adults and teenagers. So, there's changes in education, employment, there's new relationships, they may be moving house. There's a lot going on, while at the same time, they need to be looking after their chronic condition. The State of the Nation report also highlights that the age group 18 to 24 is one of the most lonely populations in Australia. 38% of people aged 18 to 24 experience loneliness and need support, peer support in particular, but also mental health support. UK data also shows that people with long-term illness, young people with long-term illness or disability, feel lonely much more often than kids and young people without chronic conditions. So it's a multifaceted issue that we're looking at here. It's not just health, it's not just mental health, it's actually social support and peer support and being connected to community, which is really important. And I think Jourdan will probably talk a little bit about that later. So type 1 diabetes is a chronic incurable autoimmune condition, typically diagnosed in childhood. It requires an interdisciplinary team to look after the child and their family. There's quite a high level of technology, medical technology, that children and families need to manage. So continuous glucose monitors, as well as insulin pumps or daily injections in order to control their blood glucose or maintain glycemic control to avoid serious complications such as diabetes ketoacidosis, which is a life-threatening complication. And it also makes sure, to ensure that future serious complications are avoided because long-term hypoglycemia or hyperglycemia can result in retinopathy, heart and kidney disease, and so on. But young people with type 1 diabetes must transition to adult health services by age 18, and that's because of the way that our health system is set up. So children's hospitals are not really meant to be seeing kids, young people older than 18 years. There are 7 good transition principles that have been developed. This comes from the New South Wales Agency for Clinical Innovation. So a good transition, a successful transition where the young person remains connected with health services, requires a formal transition process, early preparation for transition. They need to be empowered and encouraged to self-manage their condition. It always helps to have a local transition coordinator or facilitator who can help with that process. And it is a process. It's not simply sending a letter to the adult team to hand over the patient. Good communication and shared responsibility between the paediatric system and the adult system. Transition planning is really helpful. And of course, follow-up and evaluation to ensure that the young person actually has engaged with the adult team and that they are being looked after. So we did some work around, what kinds of models of transitional care there are. And we found that there are a number of significant challenges that young people face. Some of these I've mentioned before, but mental health challenges and relationships and changing relationships, as well as increasingly managing nutrition and exercise on their own, are significant challenges with which they need help. And we found that structured transition programs tend to be much more successful when those structured programs are supported by coordination, case management, in-person consultations, educational classes, etc. That tends to work best. And of course, if there's a multidisciplinary team that wraps around the person while they're transitioning to adult care, that engagement with the adult service tends to happen a lot better. The young person is able to maintain their health outcomes and able to maintain normal glycemia. As young people are very, very busy around that time, providing telehealth and virtual care options is really important to ensure that they get the advice that they need. So there are a number of different models that we identified, but one of them really was highlighted in the literature, and that's the model that runs out of the Westmead precinct, and it links the paediatric hospital with the adult hospital, and it has been shown to improve health outcomes and to maintain normoglycemia for young people with type 1 diabetes, as well as ensuring engagement with health services after they transition from paediatric care. As you can imagine, in paediatric care, paediatricians tend to look after the whole family, so parents are very involved in the care, whereas once they transition to adult care, there is less involvement of parents. But of course, this can't be, a hard stop. All of a sudden, parents are not involved at all. It needs to be managed and weaned. It's worthwhile noting that there are a number of different transition models of care that are running alongside this particular model. One is called Trapeze, the Sydney Children's Hospitals Network Transition Service. That's a statewide service. Again, this includes coordinators that help young people to transition from paediatric to adult care, no matter what their condition is. So that's completely, condition agnostic. CHIPS, which you'll hear about later. And there's a fantastic youth arts program, which is really great for making those connections and to create peer support as well. So I'd like to talk a little bit about some of the work that we've been doing over the last few years. So we've done quite a bit on type 1 diabetes and conducted a national survey around transition, and that was a survey of clinical services as well as a survey of young people who were transitioning or had transitioned. And we also conducted some interviews. And the case study, which I'll show you later on, was an observational study. We actually went into the clinics at Westmead, so both the Children's Hospital at Westmead and the young adult clinic at Adult Westmead Hospital to understand how those services actually work and how they work together. So in terms of the survey, we had representation from across the country. There were over 100 young people who had transitioned and about 69 who were preparing for transition. We had a good representation from young people from rural and regional areas as well. And we found that readiness for transition should be assessed, but it wasn't assessed very often. Only 19% of young people said that readiness was assessed before they transitioned. They were not prepared for transition, so transition was not mentioned until the last appointment for some of them. And about 20% felt well prepared, but a great majority felt somewhat prepared or unprepared for transition. So there's quite a bit of work to do in that area, and actually prepare young people early and not leave it till the last appointment. Only 24% had undertaken a structured educational program on transition before transition occurred, which is doesn't really line up with the guidelines. 6% had a joint paediatric and adult clinic consultation. So there was very little sort of joining up of the paediatric and adult services. And only 14% had met the adult team before attending their first appointment at the adult service. 22% had a written transition plan. Again, that means that 78% didn't. And even the ones who did have a plan, only 10% had a copy of the plan. So it's really important that for the young people to understand their own transition plan and to be involved in their own transition planning. Only 5% underwent group sessions where a number of young people transitioned together. And I have a feeling many of them were at Westmead and were possibly attending the CHIPS program. This is really important to do it as a group because it provides peer support for young people as they transition. So what young people told us in the survey was a little bit different to what service leaders had told us. Most of them said, yes, of course, we routinely assess for readiness for transition, but 5 services said that transition will occur even if the young person was not ready. So that's a problem. If the young person is not ready, they need to be supported before they transition to ensure that they build capacity to actually look after their own condition. 50% said that there was a structured pathway and 50% said that they developed transition plans. So that doesn't quite line up with what young people said. Not surprising, really. In terms of the level of involvement, we asked them about their confidence in managing their type 1 diabetes after they transitioned. And that was great. They were much more confident after transitioning, so they were building those skills for self-care. They felt confident about managing their condition and taking charge of their own condition. They also felt significantly more involved in discussions with health professionals. And that's also important for the long term. Type 1 diabetes, there is no cure at the moment, so it's a lifelong condition. It's really important that young people develop their capacity and knowledge to manage their own condition into adulthood. In terms of coordination, we asked them who their main transition coordinator was. So despite a number of services existing where coordination is provided, most of them said it was their mum or dad or themselves who coordinated the transition. 15% said that it was the clinic team or diabetes educator, and only 5% said that they had a care coordinator. They said peer support was important, but not easily accessed. And so models such as the CHIPS program that Jourdan will be talking about are really important. Here are some quotes. They said, I dropped out of the system once I turned 18. Nobody checked on me. I had to organise everything myself. I don't feel that there is much awareness of the impact of transition to adult care. Also, if you aren't obviously struggling, you're kind of left alone and you slip through the cracks. It took forever to get into the new adult health system, so that system capacity is a problem in the adult system as well. In terms of psychological issues, a lot of young people were needing to see mental health practitioners. There were quite some serious conditions that they reported: depression, anxiety, suicidal thoughts and self-harm, family stress and trauma, eating disorders, domestic violence. Drugs and alcohol was actually not reported very often, but it was the mental health issues that really stood out. And this is when mental health issues come to fore anyway, whether you have a chronic condition or not. But especially if you have a chronic condition that requires 24/7 monitoring, 365 days a year, there's huge stresses on these young people and their families to actually manage their condition. Okay. So going back to the case study of the Westmead Transition Clinic, I've just put a couple of papers here which you can read later if you wish. But essentially, it's an integrated and coordinated system where the adult care team works very closely with the paediatric team. So the Centre for Adolescent and Young Adult Health has been established at the Westmead precinct. This is an outpatient service for young people in transition. It's a purpose-built facility. It provides wraparound service, integrating mental health and physical health in the one place. And it's a novel young adult patient-centred service. It's located in the adult hospital, but it's tightly linked with the children's hospital clinics. It provides an integrated service. It's interdisciplinary, so there are adolescent health practitioners, there are mental health practitioners, and there are condition-specific teams that come in to use the space. It's diagnosis agnostic, as I said before, so it's developed for any team to come and use this space, as well as using the interdisciplinary team that is within this young adult clinic. We conducted some observations both at the paediatric and at the young adult clinic at Westmead, and we conducted some interviews with key informants and young people to understand how this works and what were the factors that actually helped this model to be sustained for a really long time. This has been going for more than 21 years. So this is just a depiction of the model. The key factor here is the young adult clinic coordinator. So that person is the first point of contact, both for the paediatric clinic team as well as for the young adult clinic team, but most importantly, for the young person who's actually transitioning to adult care. So we applied some work that was done with our collaborators in Norway, their patient and stakeholder involvement in resilient healthcare model, which has 7 principles. So attention to individual factors, capacity and family and carer involvement, healthcare team and staff, influence of leaders. Leadership is really important in these sorts of integrated care models. Relationships and developing strong relationships and trusting relationships across the 2 teams, but also with the young people. Assessing the care setting, is it appropriate? Is it appropriately linked? and also looking at governance structures. There are a couple of papers that I've quoted there that you can look at later. But when we applied that to our observational data and our interviewed data, and this work was led by Anne Carrigan, who was working under the grant some years ago. She's now moved to Sydney University, but she did an amazing job with this model of care. And we found that all of these factors in the model that our Norwegian colleagues developed were apparent. So transition timing was assessed based on readiness and where the young adult was on their journey, and adaptations were made based on their individual needs and preferences. Parents were involved in the paediatric setting when the transition plan was discussed, but then the young people were enabled and supported to become much more independent, but parents were still able to be involved when required. And there was really close collaboration among the health staff. So both the paediatric team and the adult team collaborated together. In terms of leadership, there was really strong leadership in this model of care. The service succession plans were in place, although just recently the coordinator actually retired and there was a delay in recruiting. And that's probably to do with, workforce shortages and ongoing pressures on the health system. There was evidence of strong and engaged leadership at both ends, at the paediatric end and at the adult end, and a holistic organisational leadership focus with involvement of young people and involvement of all teams. There were positive relationships among the young adults, carers and providers. And there was support and empowerment, accessible and transparent and visible decisions were made as a team rather than relying on a hierarchy. And young people were prepared, as we said before. This is a service that enables young people between the ages of 15 and 25 to access it, which is really great because that allows them some time to actually build capacity to then move into the adult services and be outside of the young adult clinic. In terms of governance structures, there were obviously really great processes for clinical handovers and training of staff as they left and were replaced, and of course adherence to international guidelines for type 1 diabetes. However, other factors we didn't consider when applying the framework from Norway. And I think there are some other factors that we should be considering, including policy and legislation. So the outer setting, the funding environment for staff in particular, and sharing staff across paediatric and adult services. That's often not done very well. And also community ownership of services. In terms of the setting, the inner setting, funding sources to keep the service going. You need a capable staff. You need good leadership, and as staff turn over, and they do turn over, you need to be training staff, and you need to have capacity for that. In terms of the structural characteristics, it's unusual to have such close collaboration between the adult system and the paediatric system. And I wonder whether there's something there about, the two hospitals being right next to each other, which helps. But I feel there were really very strong champions involved, and there was also policy alignment. So in New South Wales, we have quite strong policy around transition care, and we have really strong policy around integrated care in our system. But I feel there's probably a lot more work to do around these other factors. So what does this all tell us? Well, we need to improve care continuity through better integration of paediatric and adult care services. And the case study really demonstrates that it is possible, and that model has real potential to be spread and scaled up to other contexts. It needs to be structured, integrated, and interdisciplinary. Adolescents and young adults have multiple needs, including mental health and social needs, in addition to their condition. And care needs to be provided in appropriate environments, in friendly environments where they can actually meet other people with similar experiences and conditions. And of course, embedding routine psychological and peer support into type 1 diabetes care is a priority and should be done across all models of care for all chronic conditions. And now I'll hand over to Jourdan to tell us about the CHIPS program.
Thanks, Yvonne, and thank you everybody so much for having me. I really appreciate the time. And I do have some points on transition as well, Yvonne. It's actually scary how much your data reflects sort of broader transition overall. So I'm looking forward to getting into some of that, but I won't go too much into transition support. So I'm Jourdan. I'm the network manager for the Youth and Transition Department, and Yvonne so kindly shared a slide that encompasses the 3 services that I manage, which is Trapeze, the paediatric care coordination model to adult healthcare settings. We've also got CHIPS, chronic illness peer support, and there was youth arts on the slide. We need to update our website. It's now called Therapeutic Arts Initiative, that utilizes co-designing participatory models to support young people to creatively talk about their chronic health conditions and or disability, and design spaces to make them more conducive to self-management, building independence in their healthcare, and of course uses peer support structured models as well. Sorry, next slide, please. I'd just like to acknowledge the traditional owners of the land that I'm on today. I'm on Bidjigal land, but we also, as we are networked, we work with Camaragal, Barramadigal, Cabrogal, Wongal, and the Wadi Wadi people. Our services extend to the lands now known as New South Wales, and I'd like to extend this acknowledgement to any Aboriginal or Torres Strait Islander people here today, and just also hold the space for the young people that we work with across our multiple services and across the network as well. Including the Kaya setting. So I'm so glad you brought up Kaya, because I'm the ad hoc operations manager of that space, although significantly underqualified to do so, being an art therapist. So, but anyway, here I am. So as I said, I manage the Trapeze care coordination service. We have 6 care coordinators, and Yvonne rightly said, we are really limited. The transition care is fragmented. We don't have a network-wide approach to transition. We, of course, have the ACI principles, but they're not necessarily adopted by all subspecialty teams or known. So we are doing a network-wide sort of scoping project with all subspecialty teams across the network who do want to participate with us to understand barriers to transition, those facilitators and their knowledge of those transition principles before we scale that up to looking at local health district and interagency collaboration. We've got CHIPS, chronic illness peer support, which is where I'm here to talk to you today, and of course TIE, Therapeutic Arts Initiative, which I sort of briefly mentioned earlier. Sorry, thank you. This is our wonderful slide. I'm sorry that Rachel's not here. She's also an ex-graphic designer as well as now a social worker. So we get the privilege of having quite nice, fun collateral for that service. Don't look at the trapeze stuff. It's still a work in progress. Next slide, please. I won't go too far into this one, as Yvonne so very clearly outlined transition care, but as I said, it is a really fragmented and sort of fractured setting. There's a lot of incredible research happening in this space, and particularly from an individual subspecialty sort of perspective, but sort of very little shared resourcing sort of happening across the board. So we're hoping to strengthen that, and the new future health of young people and wellbeing strategy that's just coming out of the Ministry of Health, hopefully soon in the next few weeks, has set some really clear guidelines in terms of how we can support transition care outside of our model at the network and sort of be more connected with local health district settings as well. I do have a statistic here. Just wanted to, so as Yvonne said, there's 20% of young people might live with a chronic health condition and or disability. And I've got here that 40% of children as well incorporated in that. So if we're thinking about that longer term lifespan planning, it's a lot of young people that may live with one single long-term chronic health condition. Our services see young people living with multiple complex chronic health conditions and or disability and an unclear transition pathway. Of course, CHIPS, it's a singular condition, and anyone can join as long as they have capacity and they're willing to make social connections is our criteria. We're also seeing significant advances in research, as you know, and medical treatment. So the lifespan of young people and their quality of life is improving, although that's sort of putting strain on the resources in paediatric settings, and we need to expand those services and resources to adult healthcare settings. As we know, it's sort of a disparate sort of area as they change between the two settings as well. So thinking about this, young people living with chronic health conditions and or disability are more likely to experience psychological distress, isolation, inequitable access to healthcare. They require targeted support to build coping skills, confidence, independence, and capacity for self-management. And we do have so really great Scandinavian models for ideal transition journeys, particularly talking about these conversations developmentally from about 14, or some literature even says from 13 years old. So really, really important to embed those preparation for healthcare transition early on, so that it isn't, as Yvonne mentioned as well, a last consultation conversation, which I also have been in the room with young people that they realize it's their last appointment. So we're doing more and more work to sort of educate subspecialty teams to start embedding those conversations from 14 and sort of asking parents and or carers to move away a little bit, using an empowering model to have some of those one-on-one conversations with their clinicians. Thank you. Sorry, next slide. So when we think about CHIPS, we work with young people with a chronic health condition and or disability. We work more and more so with young people, particularly with multiple chronic health conditions and or disability at the intersection of a priority population status. So what I mean by that is Aboriginal Torres Strait Islander young person, a person who's experienced out of home care, LGBTQ plus populations, and our priority population subgroups are now sort of expanding in this new framework that's coming out from the ministry. Sorry, strategy, I should correct myself. We're also seeing significantly co-occurring mental health conditions. So out of the 86 members in our cohort, 30% of our young people also have a co-occurring mental health condition. They're more likely to experience psychosocial and environmental vulnerabilities because of these intersecting factors. And they may lead to disrupted development, identity formation, disruptions in education, higher school refusal, and social participation is declined, or if not limited or non-existent with a cohort of their own peers. They might be interacting with people older than them. And this is driving high health care system usage and contributing to sort of premature mortality as well. So this is where we have CHIPS that responds directly to some of these challenges, delivering developmentally appropriate responsive co-design services, and through fostered peer support, strengthening health literacy, self-management skills and independence. It also reduces isolation and prepares young people for transition to adult healthcare settings. Sorry, next slide, please. So these are our service objectives. I've just pulled them straight off our website for you to read from, and please do welcome to take screenshots at any time. I meant to mention as well. It is a youth-led peer-driven program, so we use a lot of co-design in this, unless it's sort of structured around the clinical delivery as well. But young people do come up with their own themes and directives for clinicians to explore with them in a safe setting. And as I said, we do sort of really work on those principled levels of health literacy and identity formation through those meaningful peer connections as well. I'll just go into the demographics. So we do like data, although apologies, some of it is not quite up to date. So I haven't sort of looked through what we're doing this year yet. But looking at 2024 here, you can see we do have an aging population. We are quite interested to understand why our membership base is sort of sitting around 19.5 years of age as average. I think what happens is we see a lot of sort of self discharge around 18, 19, 17 even. There's a lot of life changes, as Yvonne mentioned, and I think, you know, they're going into the workforce, they might be taking a gap year, they're finishing up their studies, and CHIPS isn't a priority, of course. And then what happens is if they're still connected with the service, they sort of come back and say their transition didn't quite go so well. They have now some additional mental health conditions that they're sort of working through. They're finding it difficult to get into the workforce, and sort of they come back to this peer setting. As Yvonne was saying, the complexity there is our age policy ends at 18 years of age. So many of our services stop at that age, but of course we are one of the only ones that continue. So where these chronic health conditions might be exacerbated, we don't provide clinical medical care there, of course, but that mental health risk that we're holding on to for those 18 years plus, and we don't have any internal referral sources to go to, that's presenting itself with a bit of complexity. So we're looking at how can we partner with community groups or have step down CHIPS models outside of the paediatric setting as well. So that's something that we're certainly looking at. I just wanted to point out we are a statewide service. We do offer hybrid version of sort of mechanisms so that young people can join us, but we do have only 3% are rural and 14 young people are from regional settings as well. So we're looking at our priority population status and thinking about how can we make ourselves more equitable to young people living outside of the metropolitan area as well. Overwhelmingly, young people are residing in the Western Sydney Local Health District as well. So we're trying to look at what we can do more from that perspective. Next slide, please. These are our top presenting conditions. They might have intersecting ones as well, but that's something that we haven't had time to sort of drill it down into the data for, but these are our primary referral areas across the network. As Yvonne rightly said, we have adopted the service now at Randwick. Melbourne's been around longer than us, actually, even, but they're a social model more so rather than that integrated therapeutic care model as well. We're the first in the country to have that approach. Western Australia has also established a service last year. I think they're taking more the social route for now, using a peer worker workforce, which is really exciting. And I believe Queensland are really interested in establishing CHIP service as well very soon. Next slide, please. So when we're talking about sustainability, and I'll try and be really, really quick here, some things that we've really adopted are looking at our prioritization tool now, because we are a clinical service and particularly looking at the mental health care needs as well. We did have a priority tool that we set up to just sort of triage the young people and better prepare them for coming to the service now. So what happens is we see the most complex young people come through, particularly referred through the psychological medicine department at Children's Hospital at Westmead. And often they weren't really prepared to come to a social setting where there's, you know, 100, there was 100 plus young people last year. We've been working on discharges. And so if a young person's been isolated for quite a significant period of time and sort of has mental health conditions along the way, it's really challenging for a young person to be plopped into a group with many, many peers. So we're trying to do a lot more work in terms of assessment, how we can support those young people to be better connected prior to coming to that bigger social setting. So having peer leaders come in and do a lot of support as well, and provide that one-on-one therapeutic support to prepare them for a group setting, and sort of looking at rules and ways of engagement in the service as well. We also make sure we do some wraparound care around the heads assessment model and just looking at their social determinants as well. So if there's anything else we can do and refer back to their treating teams, we're very collaborative there. We also have, it'll just pop up on your screen. Sorry, thank you. Just our referral pathway as well. So please do flick back and have a look at that. But they must be connected with Sydney Children's Hospital network to start with. Next slide, please. So this one is just sort of intake and discharges, I'm going to say really having a sustainable model is also looking at that goals orientation based approach and thinking about discharging. What happened with us, we had about 120 young people enrolled in our service and only 2 FTE to manage that. And with the mental health complexity in particular, or complex and multiple conditions for some of our young people, we just could not keep up with the demand on the service. So thinking about service caps and looking at goal setting for young people is really, really important, particularly if you're sort of thinking about some young people that don't really need the service anymore and they're looking at other models for young people such as youth councils and other community related supports as well. So really, we really want to focus on young people that really need that socialization. Next slide, please. And we're just looking at ages of discharge as well. So this is something we're really interested to know, particularly as we sort of intersect with that transition age and what it sort of is happening there so that we can be really responsive as a service. Next slide, please. If we look at attendance, we've got really fun punny names, potato related. Potato peels is more of our, as I said, I'm an art therapist and we have one employed. Potato peels is more talking about their feelings. So it is a psychosocial group for young people. They might talk about themes such as uncertainty, living with a chronic health condition, feelings of being burdened is often one that comes up, or grief. Or dealing with sibling dynamics, things like that. Solo Spuds is our self-management group. Creative Connect is one of our more overwhelmingly interesting areas for young people to come, and we do try and look at how we can connect with TIE, so it's still healthcare related work. So we did a podcast, for instance, which I'll bring up as well. It's all directly related to health literacy. And then we do still have the social events and activities, of course, which is the core integrated group that CHIPS originally was. So I've just got the side-by-side comparisons. And we've been really working here on increasing attendance because we had a fair bit of staff leave last year. So we've got a 13.2% increase in coming to our programming. We wanted to make sure that our groups were meaningful. We recognized last year we had about 3 to 4 young people coming to each group and we were offering too many, so it's oversaturated. So we're still working out the balance there, of course, and we need to maintain that therapeutic aspect. Otherwise, we need to sort of think about, do we belong in a tertiary healthcare setting or is it more community-based? So we're trying to sort of work out what's happening there, particularly with what NDIS is offering, of course, as well. We also included, next slide, please, sorry, individualized support. So we recognized some young people that were quite vulnerable, weren't coming to group settings, but wanted to connect with an individual clinician. So we offered individual support with the goal of after 3 sessions, they must come back to the group setting. And these are some of the key reasons why they were not coming to either CHIPS programming or were not attending their appointments and outside of the CHIP space as well. So that was just something we anecdotally sort of collected as we went along. But really interestingly, we were sort of looking at that self-management and mental health component, and particularly being the transition service of the network, we were sort of looking at how can we make sure that we're better integrated, of course, with the rest of our department. And I might just flick through. The next slide is just the service delivery in terms of how we offer it, of course, which I've mentioned. And the next slide is, again, the punny service streams that we offer. So we do have an introductory group. It's mandatory. Young people sort of come to this and they talk about effective communication, setting boundaries as a peer group, of course, and respecting difference and how to communicate with each other. And then after that, they have access to the full suite of the streams. We are not a mandatory service, but we do have sort of rules for engagement. So if a young person doesn't connect with the service for a year, we try really hard to reconnect them, or even 6 months now actually, and think about what some of those barriers are, but we try to do that quite frequently. And the next slide, please. Sorry, I don't want to take up too much more of your time. We do have a leadership model as well, so really important that you think about that loop of leadership peer support in that space. These are the different offerings that they're accessing to, and looking at the VIA character strengths is a new thing. They love a quiz, and so looking at what their individual strengths are and how they can bring back that to the community is really important. And the next slide shows their current projects that they're working on, which is really exciting for them, and I can't wait for those to come out in the report. Something I will say is the service has gone through periods of, oh, sorry, you can move along. Thank you. That was very well timed with my gap there. Thinking about peer models, it does go through group dynamics and sort of it is in its adolescence phase again, so to speak. So we've had a few challenges in the last couple of years with the way that the service has been structured and needing to change and be responsive. So of course, being clinicians in the space, we need to ensure that the environment remains respectful. So we did develop the CHIP Safer Space guidelines so that young people could understand the responsibilities of clinicians to support them, as well as our expectations for engagement. And so that risk just sort of happens. We do have quite a broad age range from 14 to 25, so really important that we're developmentally appropriate across the ages there. And last couple of slides, we've got our service goals for 2025. We are on track. Hopefully, if I'm ever given a spot to speak again, I would very gladly talk to you about what we've managed to get through for 2025. But as I said, we're sort of in a period of collecting data and understanding how we could be more responsive. And our last slide there, just talking through the tips of implementation and sustainability of a peer support program. So we are developing condition-specific peer support models across the network. We've got one with the heart failure and transplant service and complex asthma, and we're really sort of struggling to look at what can we do to support those young people, because as Yvonne's slide suggested, there's a lot of complexity that's sort of happening for young people. So adopting this non-condition peer support model to an inpatient condition-specific one is our current sort of focus as well. And then lastly, just working with co-design methodologies, we end up with some really nice projects. Like on the next slide, we've got the Chronic Conundrums podcast. So I really do hope that you all take the time to listen to that one. It does feature our staff specialist, Dr. Jane Ho, who talks about the importance of healthcare transition, and all of these young people that worked on this project live with a chronic health condition and or disability. And that's it from me. I'm so sorry I took up so much for your time. I really, really appreciate you giving me this platform to speak.
Thank you so much, Jourdan. That was fantastic, and please don't apologise. I think I should be apologising. I took quite a bit of time that I didn't mean to. Shall we open up for questions, either online or in the room? Any questions for either of us? Just unmute yourself and speak up.
No questions from us here in the room, Yvonne, but I will distribute the slides and a lot of those links that Jourdan and yourself mentioned in the slide. So we will send that out next week for you. Stephanie.
Hi, thank you both. That was fantastic, and absolutely no need to apologise. It was really, really interesting to hear sort of how that project had come together and that whole integration, and especially sort of all that working with young adults. One of the things that I was to pick up, and I think it was something that you were talking about, Yvonne, was that the findings that you got from the young adults that you captured data from and the service providers was really different. And I was just really interested in what the young adults thought about that. Did they find that amusing? Did they expect it? Was it sort of something surprised them, or it made me smile anyway?
Unfortunately, they expected it. And it's really interesting. We spoke with service leaders mainly in metropolitan centres. And so, even those leaders, not all of them had structured transition programs. So I think in the country in particular and in, other regional centres, it's quite difficult for young people to transition. The services do tend to be concentrated in our metropolitan centres.
Yeah.
Yeah.
Well, thank you anyway. Great presentation. Great work.
Thank you. Any other questions? We have 2 minutes. Sorry, guys. Another question, but I'm embarrassed at how long it took me to make the link between chips and potatoes. Welcome, David. I believe this is your first time. You're more than welcome. Yes.
And what a way to join a group. So thank you for having me.
All right. If there are any further questions, or if you would like to contact us, we're very willing to have a chat offline. And the presentation will be on our YouTube channel anyway, so you'll have access to all the things that we quoted and various QR codes, etc. Don't be shy. If you have a question or you want to work together or do something together, by all means, give us a call or an email.
Wonderful. Thanks, everyone.
Thank you for having me.
Thanks all. Thanks, Tina, for organising.